Hi everyone, welcome to our webinar titled Preventing Pediatric Window Falls, a collaborative approach to effecting National Building Code change facilitated by the Fall Prevention Community of Practice. My name is Shamiza and I am the Knowledge Coordinator at the Ontario Neurotrauma Foundation, also known as ONF. ONF sponsors the Fall Prevention Community of Practice Loop and Loop Junior along with the annual Fall Prevention Month campaign. So before we begin, I'd like to give you a quick rundown of the Zoom meeting platform, like always. So your screen, just switching screens right now. So your screen may look a little bit different depending on the type of computer that you're using. So if your Zoom application is open in full screen, you can double click or press the escape button on your keyboard to exit the full screen. There should also be a button on the top right corner of your screen that says exit full screen. On this slide, you'll see that I've circled in red where the exit full screen button can be found. The webinar technology consists of two parts, audio and visual. So both audio and visuals are provided through your computer monitor and speakers. So to test or adjust your audio settings, look for the audio settings button here or the join audio button on the bottom left corner of your screen. So it may look a little bit different depending on your screen. So this will provide options for testing your computer, microphone, and speakers. So if you look to the bottom center of your screen, you will see buttons that will allow you to access the chat box, raise hand, and Q&A features on Zoom. So the chat box allows you to send messages to webinar presenters and other webinar participants. And you can use the raise hand button if you want me to connect with you through the chat box. And you can submit questions through the Q&A box down here. So you will only be able to view questions that you have asked, not questions posed by other participants when using that Q&A box. So to simplify things a little bit, for technical questions, please use the chat box. And for topic-related questions, please post them in the Q&A box. And if you need to leave the webinar at any time, click the red Leave Meeting button at the bottom right corner of your screen. So if you have, not to worry, if you have any questions throughout any time in the webinar, please reach out. And my colleague Cynthia Menzies will also be monitoring the chat box and the Q&A box, so she can also assist with any of your questions. You can email me at shamiza.allard@onf.org. I've included that information in the chat box if you have any other questions that you want me to help you resolve. So as an FYI, the webinar is being recorded and a YouTube link will be sent to all participants in about 1 week along with the presentation slides. Okay, so I would like to now introduce our presenters, Dr. Michelle Simonelli and Mr. Bruce Schultz. So Dr. Michelle Simonelli is a Pediatric Emergency Room Physician at the Alberta Children's Hospital, also known as ACH. She has been the ACH Medical Director of the Canadian Hospital Injury Reporting and Prevention Program, also known as CHIRPP, since 2015 and a member of the ACH Trauma Committee since 2017. In her capacity as CHIRPP Medical Director, she is one of ACH's injury prevention experts and regularly collaborates with other medical subspecialists and non-medical injury prevention experts to identify key patterns of injury and develop effective prevention strategies. Mr. Bruce Schultz is a graduate of the Northern Alberta Institute of Technology, the Architectural and Technology program. He worked for architectural design firms from 1979 to 1986. His regulatory career began with the Alberta government in 1986 and continued to 1998. He has been with the City of Calgary since 1998 in the areas of plans examination, inspections, evaluating alternative solutions, training, and special projects. Bruce currently is a member of the National Research Council Standing Committee on Fire Protection, where he is a member of several working groups and task groups and chairs the task group on combustible construction. He represents the City of Calgary on research consortiums with the National Research Council and is a member of the ULC Standards Task Group on Fire Stop Systems, in addition to being a member of the Building Sub-Council in Alberta under the Safety Codes Council. Bruce is also a recent member of the NFPA Committee on Residential Sprinkler Systems. So without further ado, please take it away, Bruce and Michelle. You may now share.
Good morning. It's Michelle speaking. Thank you so much for the introduction, Shamiza, and for the invitation to present at today's webinar. It is our pleasure to discuss with you our journey to change the National Building Code to help prevent pediatric multi-story falls from residential windows. We'll start by identifying the problem, specifically the key role Bruce and Marco Civitarese had at the City of Calgary Building Department in identifying the problem and their leading role in affecting change. I'll then discuss my role in collecting the injury data and presenting the medical viewpoint. Bruce will discuss the lengthy journey and our progress thus far in changing the National Building Code. And then together we'll discuss next steps and end with Bruce discussing opportunities he sees for IP professionals to build relationships with key regulatory groups to help us advocate most effectively for regulatory change. I hear, and I'm not sure if this is still the case, that the weather is not too bad out in central and eastern Canada at the moment. However, winter has most definitely arrived out west, and already I'm feeling that spring could not come soon enough. And while I'm looking forward to the warmer weather, the longer days, the return of the Canada Goose, what I dread is the onslaught of small kids falling out of windows that we see with alarming frequency every spring across Canada. Well, as pediatric intensive care unit and trauma doctors, every spring we see kids falling from windows with alarming frequency. It was truly when this problem was identified by Mr. Marco Civitarese, who's the Chief Building Official and Manager of Building Regulations, and Mr. Bruce Schultz, Codes Officer in the City of Calgary Building Safety Department, that the wheels of change were actually set in motion. Marco and Bruce were rightfully alarmed by the rash of pediatric falls from windows dominating our local headlines in Calgary every single spring. It was their expertise with building safety codes that allowed them to identify the problem. Why was this happening? And it was their determination to resolve it that started the journey to change the National Building Code that we will outline for you today. It's my pleasure at this point to turn the floor over to Bruce as he explains the heart of the issue.
Thanks, Michelle. The first thing we did was trying to identify the problem, and the building code is less restrictive for single and two-family houses than it is for multi-family houses. We realized that the tragic falls were largely a result of the flaw in the code that did not adequately consider and protect the safety of children in either single-family or duplex dwellings. The code as it currently exists allows fully openable windows on the second and third stories of a single-family dwelling to be at floor height, as seen in the image here. Many of you will recognize the photo on the left as being a typical suburban bonus room above the garage. Adults see this as a low-placed window, but if you imagine yourself as a toddler, what you see is a patio door with no patio, no guardrail, from which you could easily fall onto the concrete driveway below. The photo on the right is the result of an unfortunate fall from a second-story window through a screen, which, by the way, is no longer required by the code. Even though a screen was never designed as something to hold back a child. The child can actually, in this case, hit the edge of the fireplace projection on the main floor before falling to the ground. Fortunately, the child did survive. But as you can see, windowsills for openable windows can be at the floor level for single-family dwellings, and that's problematic. This slide provides three illustrations that address or illustrate the issue. The first one on the left shows an example of a single-family home where a balcony would have to have a guardrail, but a window right beside the balcony that opens to the floor level would not require a guardrail. And that's one of the inequities in the safety requirements in the building code. The middle photograph shows an illustration of a spring-loaded limiter on a window. And this one happened to be on the 6th floor of a residential building, and they're easily disabled. It's spring-loaded, easily disabled by a child, and in this case, there was an incident where a child did fall from the window. The photo on the right shows two different scenarios of a single-family dwelling across the street from a multi-family dwelling, where the requirements are different, but the hazards, as you can see from the illustration, are exactly the same. So why are the code requirements different? And that's what we were looking at. So on the left, you see is the National Building Code as it currently exists for openable windows in single and duplex dwellings, with the highlighted emissions in red and additions in green. And this is just sort of one portion of the proposed changes that were put through. But it's meant to show you that there was a fair bit of change that was required to happen. And I realize that in medicine you deal with a very specific and complex language. It takes years to become fluent in it and understand its nuances. In Marco and I's case, despite years of working with these codes, we're still working on what we call codeese, the language of the code. And on top of that, the language is developed by committee. And that has its own complications of arriving at a consensus. So what we identified was that a problem in the NBC is it was written allowed windows on the second and third stories to be openable from floor level in single and duplex residences. But the building code for multifamily homes does not allow this. So we could simply make the codes restricting windows in single family and duplex homes consistent with multifamily homes. Then the problem could largely be solved. Hence the new proposed code requirements that show up on the right there is basically an openable window in a single and two-family residence would be the same as for multifamily dwellings, and it would require either a guard or a limiter limiting the opening to no more than 4 inches or 100 millimeters. And it would have to be more permanent than just a spring-loaded button. Minimum 900 millimeter sill above the floor instead of being right to the floor, or maximum 70 inches for the sill to be above grade. So at least if the child falls, it wouldn't be as much of a fall as they can fall now. So all this makes intuitive sense, but to change that, the code needed to convince, we needed to convince all of the many layers of the committees along the way that this fault in the code was a genuine safety concern that necessitated urgent action. And that's where Dr. Simonelli came in, with the hard evidence to prove the problem without a doubt.
And so in my role as CHIRPP Medical Director, again, CHIRPP being the Canadian Hospitals Injury Reporting Prevention Program, I became involved. Back in 2012, the City of Calgary approached the Alberta Children's Hospital Trauma Director, and when I came on a few years later to start as CHIRPP Director, I became directly involved. In that, Bruce and Marco required data to demonstrate the severity of problems so they could motivate the many subcommittees and subcommittee members along the way that this was an urgent problem. They also, as we moved further along in the process, required assistance from the medical community to advocate for urgent care and demonstrate that this truly was a national issue that engaged and affected medical and injury prevention professionals across the country. And so in order to demonstrate the need for change, I was asked to provide information to people who weren't familiar necessarily with the data. And so what I told the architects, the engineers, the builders, the codes officers, the fire safety experts, well, most of us on this webinar already know that in 2010, injuries killed almost 16,000 Canadians, hospitalized over 250,000 of us, and resulted in 3.5 million emergency department visits at a cost of almost $27 billion. Unfortunately, as we know, the numbers are rising. And if we keep increasing at our current rate, by 2035, we anticipate injury will kill over 26,000 Canadians, leave over 80,000 Canadians permanently disabled each year, and cost $75 billion annually. I also told these building experts that the situation is most dire for children and young adults. Unintentional injury is, by far and away, the leading cause of death of young Canadians. In fact, unintentional injury kills more Canadian children than the next 2 leading causes of death combined, including all childhood cancers. Put another way, 1 of 3 Canadian children who die this year will die as a direct result of unintentional injury. But as we know all too well, injury deaths are only the tip of the proverbial iceberg. Most of us are familiar with the injury pyramid. In 2010, 211 Canadian children ages 0 to 14 died as a result of unintentional injury. Almost 15,000 were hospitalized, and over 680,000 visited emergency departments. That doesn't begin to capture children who see physicians in urgent cares or other clinics, or who don't see a physician at all after being injured. But how about pediatric injuries resulting directly from falls? As with adults, falls are the leading cause of injury admissions and emergency department visits in Canadian children. They are responsible for 42% of injury-related hospitalizations and 36% of injury-related emergency department visits. But what about pediatric falls from windows specifically? Anecdotally, every emergency doctor in Canada and anyone who pays attention to the local news headlines knows this is an issue. At the Alberta Children's Hospital, it is an injury we see frequently every single year. So how big was the issue at our hospital? Over the past 5 years, we've seen a low of 7 of these injuries and a high of 20 of these injuries every year in kids less than 10 years of age, ages 0 to 9. And in fact, in 2016, 23% of ACH major trauma patients were injured in a fall. 56% of these major trauma patients were multi-story falls from windows. So why does it happen? This image of the little girl speaks very well to the problem of pediatric window falls and the group at highest risk, young children ages 1 to 4. Children live in a world designed and built by adults. Children this age explore the world tactically, hands and head first. And they have 3 things going against them. 1, increasingly able bodies. 2, increasingly curious minds. And 3, a very unique anatomy which predisposes them to particularly devastating injury patterns if they do fall. I'll come back to the unique anatomy a little later in this presentation. But how big is the problem nationally? That was the core question we needed to answer to be helpful to Bruce and Marco. So to understand the national scope of the problem, we needed to gather data at the national level. The data sources are numerous, but our data came largely from CHIRPP via 3 specific databases. So the first is NACRS, the National Ambulatory Care Reporting System, which is an excellent data source that includes information about emergency department visits. However, it collects data at present only in Alberta and Ontario. So while it's invaluable information, it's unable to give nationwide emergency data for these falls. So the second source of data was the Hospital Morbidity Database, HMD, which collected nationwide hospital admission data until 2011 for all the provinces, and then was replaced by the DAD, or the Discharge Abstract Database, after 2011, which included all provinces except Quebec. So queries of these databases allowed collection of invaluable nationwide hospitalization data for falls, albeit still not fully allowing us to answer our question. So the last data source is CHIRPP, the Canadian Hospital Injury Reporting and Prevention Program, that collects data from 19 hospitals across Canada, mostly pediatric. It is funded by the Public Health Agency of Canada with a mandate to collect information on every injured patient that presents to any CHIRPP institution emergency department. The CHIRPP data was an invaluable source of primary data, which was instrumental for us in scaling the data from the 3 CHIRPP sources above. This is just a quick review of CHIRPP. As I mentioned, there's 19 national CHIRPP emergency department sites. What happens ideally at these emergency department sites is that every child who presents with an injury will be presented with a form. The front of the form collects descriptive data by the patient and or their families that would itemize the date of the injury, the location of the injury, the mechanism of the injury, and allows a free text description of the injury, collecting very rich descriptive qualitative data on all the injuries. The back of the form is then filled out by the healthcare provider, outlining the nature of injury, the body part injured, the disposition for the patient, and any ultimately required follow-up. This data is then entered into the eCHIRPP database, which resides in Ottawa. And once the information is in the eCHIRPP database, we are able to do site or nation-based queries of the data as far as injuries collected in the database are concerned. So what does the data show? The CHIRPP data indicated that from 2011 to 2016, an average of 124 children ages 0 to 9 were admitted to Canadian hospitals for falls from buildings every year. Now there's 2 important things I'd like to mention about what this data does and does not tell us. It includes only children hospitalized after their falls. It does not tell us how many children fell from buildings. And secondly, it provides information on injuries coded ICD-W13. So that's the International Classification of Disease Code W13, which collects falls from buildings. This classification includes falls from balconies, which is clearly an important contributor for falls for children, as well as falls from things such as roofs, bridges, towers, turrets, aqueducts, and flagpoles, which I would argue are much less relevant to prevalent mechanisms of injury for children, particularly in the 0 to 9 age group. So we needed to dig deeper into the data to determine what percentage of these children actually fell from windows. So the first column in this slide gives the same data seen on the previous slide for falls from buildings for children ages 0 to 9. We then turned to the senior epidemiologist and statisticians from CHIRPP at the Public Health Agency of Canada, who may in fact be tuned in, so thank you. Based on all the data sources I've described, it became evident that conservatively, we could estimate that approximately 70% of falls coded ICD-W13 are in fact for falls from windows. This gives us the next data point, such that an average of 87 children aged 0 to 9 were admitted to hospitals across Canada every year after falling from windows between 2011 and 2016. Again, however, this is information for kids who are admitted to hospital for falls from windows. But how to derive emergency department visits from this data? How to figure out how many children are actually falling from windows? Using NACRS and CHIRPP data, it was determined that an average of approximately 20% of children who were seen in the emergency department for falls from windows are admitted to the hospital. This gives us the last column of data. So based on our best possible estimates, based on the best available data, we conservatively estimate that an average of 433 children are treated in emergency departments across Canada each year for falls from windows. I'll remind you again of the injury pyramid. While we can expect that most children who fall from windows will see a doctor, not all of those children will be seen in an emergency department. Some will be seen in urgent care centers or remote medical clinics, and these kids are not captured in our data. Moreover, these numbers do not include children who did not survive to be transported to hospital. So there is no doubt in our mind that this number underestimates the number of children who fall from windows each year. So this brings us to the limitations of the data. And we know there are limitations in our current data. First would be consideration of the robustness of NACRS and DAD. We know the provincial annual accounts less than 5 are suppressed in order to protect confidentiality. Within the NACRS mandate, it will specifically quote jurisdictions that choose to participate, from which we infer that there are jurisdictions who are not participating in NACRS. And what's interesting for us is that the NACRS and DAD data indicate that Ontario has less than 2 times the number of window falls of Alberta, despite having 3.3 times the population. As evidenced in this slide. The question for us is, does this represent a flaw in the data or significant differences across the provinces? Are there differences in architecture? We do know that there are fewer single-family and duplex homes proportionally in Ontario than there are in Alberta. Single and duplex homes represent 58% of homes in Ontario versus 65% in Alberta. Is there potentially a smaller proportion of new construction with low second and third story windows in Ontario versus Alberta? The differences in climate we have to figure are going to play in. While it's very common to have air conditioning in Ontario, so to keep the windows closed in the summer, it's very unusual. There are very few houses in Alberta relative to Ontario that will have air conditioning, and so we tend to achieve ventilation in our homes through opening the windows. Is there increased public awareness in Ontario? You're simply better at putting the word out to Ontarian residents than we are here in Alberta. Or is the data incomplete? AHS benefits from one provincial health authority, Alberta Health Services, that administers to the entire province and all jurisdictions within it. And perhaps as a result, it's easier to collect complete data in Alberta versus in Ontario. We are unsure. But we do know that the data is an issue. Fortunately, we have some interesting research about to be published from Stollery Children's Hospital in Edmonton that can help us increase the robustness of our data and give us more information about demographics and circumstances of these falls. The window and balcony falls related pediatric injuries in Northern Alberta study is currently under review and for publication by Drs. Kundra and Drs. Craig at the Stollery Children's Hospital. It's a retrospective review and 2-year prospective study from Stollery from 2009 to 2017. During that period, they had 107 falls from buildings, so that's 15.2 per year for children under 17 years. The mean age was 5.14, median age 4, mean height of the patient 110 centimeters. So we're dealing again with the same small children we're seeing at the Children's Hospital in Calgary. 63% were boys, 55% fell in their own homes, 50% fell through window screens that are no longer required. But most interestingly, and this speaks to what Bruce has been talking to at this point, only 20% of the windows these children fell through had sills that were higher than knee height. Essentially had openable portion of the window opening almost at floor height. and this is what facilitated the falls. Also, 28% had furniture pushed up to the window, and 28% of these children were admitted to hospital. This data is largely in line with what we see at the ACH emergency from our CHIRPP data, where 66% of the children who were falling from windows are 4 years of age or less, 78% are 5 years of age or less, the majority are boys, and the majority are falling from their own homes. So what about injury patterns from these falls? So I had access to the injuries of children seen at Alberta Children's Hospital and Stollery, the two Alberta Pediatric Trauma Centers. And we saw that 28% of patients seen in the emergency department for falls from windows were admitted to hospital. This is notably higher than the average of 20% we've used earlier in our data, but it represents a very well-known referral bias inherent in big city trauma centers, in that we see the children who are sick enough to be sent in from smaller centers, and therefore we admit more of them. We see that the majority of admitted children have skull fractures or traumatic brain injuries. Other injuries include cervical spine fractures, facial and long bone fractures, splenic or liver lacerations. We know that 53% of Stollery admissions required surgery based on Drs. Kundra and Drs. Craig's study. It's interesting to note that even in the trauma centers, almost 70% of kids can be discharged after assessment and treatment in the emergency department, including casting of broken bones, etc. So a remarkable number of these kids get lucky enough to go home despite this incredibly dangerous mechanism of injury. And this is because what we're dealing with is a blade's edge. The margins are so narrow, and we cannot protect which kids will escape unscathed and which kids will go on to have devastating head injuries with permanent disabilities resulting from their falls. There are numerous variables at play that can affect the number and severity of injuries for a child. There's building architecture, the height of the fall. There's the roof lines, falling out of a window onto a roof that might slow or change trajectory of the fall before a child hits the ground. There's the landscaping considerations. Children who are falling onto bushes or grass are going to suffer less severe injuries by and large than children who fall into concrete or deck or hard landscaping that's immediately beneath the window. But the age and size of child is also key and perhaps one of the most important considerations. Because as we've seen, traumatic brain injuries are common with this type of fall, and it speaks to the unique developmental anatomy of children that I mentioned earlier. As you recall, the mean and median age for children with these types of falls are young, children in the age or in the vicinity of 4 years of age. By the age of 2, children will have a skull that reaches 90% of its adult size, but have a body weight only 15% of an average adult weight. This means that young children have a much higher center of gravity than adults and are much, much more likely to fall head first, particularly as they explore the world with their hands in their head, like the little girl in our opening image. This high center of gravity, in addition to everything else we have already discussed, increases the risk of devastating head injuries. And so, in order to make the case for the change, I was asked to discuss the costs of these falls, which in Canada is no easy task. First and foremost, there is a human cost, and I can't understate the absolutely devastating impact these injuries have on the injured child, their families, friends, and communities. It's truly something I will never forget for every child I've managed in the emergency department trauma bay who's fallen from a window. For costs to the healthcare system, I explained the difference between direct and indirect costs. I explained that falls in children 9 years of age and under cost the nation almost $1 billion in 2010 alone based on our best available data. I explained that we know that multi-story falls are the most severe of pediatric falls and that most children admitted for these falls were under the age of 5 and have a traumatic brain injury for the reasons we've already discussed. The younger the patients, the higher the cost. For some quantification of the public monetary costs per injury, I looked to this study from the UK, and while our healthcare and social services are not identical, they are in many ways comparable. This study estimated lifetime costs in the UK of a child experiencing traumatic brain injury at age of 3 of approximately £4.89 million, or $8 million Canadian per child injured. For those of us who know children who have endured an early childhood traumatic brain injury, these costs seem very much in line with Canadian experience. And so the costs, both human and monetary, are immense, and therefore our journey to change the National Building Code had a significant importance for us. Bruce will now discuss that journey.
So when we look at the codes and what we can change, the first question that comes to mind is why the National Building Code? And the reason for that is in Canada, the National Building Code is a model code for Canada. National Research Council has a system that develops the National Building Code, in addition to the National Fire Code, as model codes for provinces to look at. Each province then chooses how to adopt the code within their jurisdiction. In this table here, you can see the differences between the two, between the provinces in Canada, provinces and territories, and how they deal with the national code. In Alberta, we're trying to harmonize as much as possible with the National Building Code, and sort of on the other end of the extreme of the harmonization is Ontario, where there's not as much harmonization. And there's Quebec is sort of in between Alberta and Ontario, and then there's the other provinces and territories that adopt more closely to what the national is. However, in Ontario, the latest Ontario Building Code does have the same requirement as is currently in the National Building Code when it comes to the windows and the window safety. Each code cycle, we call it, takes about 5 years, or takes 5 years. The next code, next national model code is due out in 2020, and every 5 years after that. The adoption process within the provinces varies by province. Sometimes some provinces adopt them as soon as they come out, and some provinces need legislation to adopt them, so it may take anywhere from 1 to 3 or 4 years after adoption before they actually adopt the provincial code or the national code in whatever form they're going to adopt it. So when we looked at the change, we instead of just saying an Alberta change, we went nationally in order to get the national code changed, because that's the way Alberta is going. So in order to make things happen, there needs to be a champion for the change, and that's where we stepped up. To be the champion for the change, there has to be someone who knows the code and the process and can shepherd the change through the process. The champion needs to draft the change, get it onto the agenda of a subcommittee meeting, and convince everyone else at the meeting that the problem is an urgent priority, above all the other many competing interests. And in the particular standing committee that this went to, there is a lot of competing interests. Then all of the experts need to agree on the intent and wording of the change. As I mentioned before, it's a committee situation, so consensus on wording can be challenging. It needs to go through a subcommittee of a task group on stairs, handrails, and guards in this particular case, and then the task group needs to get this onto the agenda of the standing committee and get the standing committee to appreciate this as a priority over all other competing changes. And those roughly 30 people on the standing committee need to accept the change. And only then does NRC put forward the change, the code's proposed change, for public review during each fall. There's a public review phase that happens for any changes that are ready to go for the next code, instead of waiting until the very end to put them all out. In this case, there was also a parallel process that took place provincially as we were trying to get the change to happen in the Alberta Code before it would happen in the National Code. Alberta did recognize, the Minister of Municipal Affairs did recognize that there was an issue, but preferred to wait for the harmonization with the National Code. So we kept all our energy on going the national process. As you can see from the timeline, it takes quite a few years to get to the point we're now at, which is the last step shown on the bottom right. There's a lot of, these are just the major steps that we went through. There's a lot of numerous smaller discussions and meetings and events that are not shown, just be too numerous to show. But throughout all of this, the support of the medical community has been incredibly invaluable, whether people were participating as observers on the teleconferences, or whether it was people like Dr. Simonelli coming in person, I believe it was to Ottawa, to make a presentation to the standing committee. So that, as you can see from the timeline, it took us a few years to actually formulate the proposal. We had an idea in our minds of what we wanted to do, but we needed to have the information, the support, the statistics, and the data to go with it. We didn't know where to get that. And Marco managed to stumble across some contacts in the medical community, and that's where things got started. We submitted the code change proposal to NRC in 2016. NRC then determines which standing committee it needs to be forwarded to. In this case, it's the Standing Committee on Housing and Small Buildings, and I'll show you the structure in a moment. The Standing Committee then forwarded the code change request onto a task group to look at it in more detail. The task group provided a recommendation back to the Standing Committee, and then it went for public review. The task group then reviews the public review comments, and that's to respond to each of those comments. And the task group makes a recommendation on those comments to the Standing Committee. The Standing Committee, once they're comfortable with the change, then recommends to the Canadian Commission on Building and Fire Codes for it to be included in the next code. And that's where we're at right now. The recommendation from the Standing Committee has gone to the Commission. The Commission will be meeting in December to make that final choice of whether or not it will be going into the code or whether it needs further work. So that's the point we're at now in the process. So when we look at addressing a code change request, what sort of information is needed? So there's a number of basic questions that are required to be answered as part of the request. First and foremost is data. The more, the better. It helps in identifying the problem, first of all. And the cost benefit is also where the medical community can assist and provide the cost to society of the consequences of not changing the codes, as Michelle provided a few minutes ago. This is a major piece of the information that Dr. Simonelli was able to provide for the task group and the Standing Committee to support the change. We basically need to know what is the problem. So we knew what the problem was. We just didn't have the data to support how big a problem was. What the proposed solution is, so we need to propose language, what the stated objectives and functional statements of the code, the code being an objective-based code. All of the articles have an objective and functional statement to go with them. The cost benefits is what Dr. Simonelli was able to provide, and then what the enforcement implications may be. The result of the public review, where the code change request was put forward, was there was 103 supportive of change as proposed comments, and that was due in large part to Dr. Simonelli mobilizing the troops, so to speak, and getting the medical community to provide supportive comments. Some of you online may have been some of the ones that provided those comments. There were 9 supportive of change with minor potential modifications, and there were 2 non-supportive and request modifications. And those last 2 categories are the ones where the task group and then the Standing Committee needed to concentrate on to address, to see if those things were already considered or if they were bringing up items that had not been considered. The bottom line is it was a huge win from both Dr. Simonelli and my point of view and Marco's point of view. At this point, we're 95% confident that next month, or now that we're in December this month, that NRC will take the final step and accept the code change. To change the construction of second-story windows to keep children safer. The building codes are provincially enforced, and with most provinces adopting the national model codes within a few years of the NBC being released, it's going to take another 2 to 5 years before this will actually be in some of the provinces. But it is a great victory for new homes, and it does point to a safety issue with some existing homes that we'll talk about in a bit as well.
So while this is a huge win, without a doubt, and we again are very grateful for all the help we've had from across the country, including some of the people on the line now, we also have to ask if the injuries that can be prevented with the new code for new construction represent simply a drop in the bucket. Is this going to represent simply a slow change that won't have foreseeable effect for decades? Because as you can see, there were over 14 million dwellings in Canada in 2018, approximately 8 million of which are the single-family and duplex houses that will fall under the jurisdiction of the new code. In 2018, there were 80,000 single and duplex new housing starts, so only approximately 1% of dwellings are going to be subject to the new code every year from a new construction perspective. And not every province is going to adopt the new code right away. However, not all the current housing stock has non-conforming windows. In fact, I think it's safe to say that many houses built before the era of bonus rooms were built with a different design aesthetic that was much more uniformly compliant with the goals of the new National Building Code. Moreover, the code also applies to renovations. So anybody renovating a house that's a single or duplex dwelling will have to meet the new code requirements with respect to windows. Furthermore, the changing national energy standards also make a case for smaller windows to decrease energy consumption, which can also play to our favor. Furthermore, we have seen on numerous fronts that changes to the construction of building is not the only way to keep children safer. The best parallel example I can offer is that of stair guardrails purchased and bought by families when baby-proofing their homes. And parents go to great lengths to protect kids from access to stairs. You can check that out. These are not mandated by the building code, but I think few of us can imagine that parents of crawling children don't realize the importance of installing these types of guardrails in their homes. But like so many things in injury prevention, this reflects a societal paradigm shift. At some point in the past 2 to 3 decades, parents became aware of the risks of children falling downstairs, and these devices became readily available, and now people use them. When we see young children in the emergency department who have fallen downstairs, more often than not, parents will acknowledge that they recognize this was a risk that they had attempted in some ways to mitigate. They'll explain that they turned away for a second but didn't have a chance to close the gate, or that they have the gate but didn't install it yet because the baby just began crawling last week, or they'll say they had the gate and an older child left the gate open. So there's a clear recognition on parents' behalf that this was a risk, and they'll go to dramatic lengths to protect their children from it. The irony is that most kids who fall downstairs actually roll down the stairs, and most of the children I see in the emergency department with this type of injury aren't terribly injured. But kids don't roll down the side of a building. They're an actual free fall from height. And what's striking to me in all the cases I've managed of kids falling out of the windows is that their parents never even appreciated that this was a possibility. It simply wasn't on their radar that their Canadian houses built with all sorts of safety codes in place could be built in such a way that their young child could actually just fall out of a window on the 2nd or 3rd story. It was truly beyond comprehension for them. And if they don't appreciate the risk, they can't protect for it. Even though there are devices on the market, they're actually far smaller and less obtrusive in most cases than those ubiquitous baby gates. So there are lots of things parents can do to protect children from falling out of windows if they're aware of it, that it's a risk. And Bruce will tell us now about some of them.
There are a number of different aftermarket devices that are available to meet and meet recognized standards. The device on the left is a lever type button that is activated on a window, but in order to meet the standard, you need 2 of these buttons. So it would require 2 actions or actions by 2 different hands at the same time, one down low, one high, for example. The other 2 devices, other 2 photographs are devices that can be retrofitted into a window afterwards and are available at hardware stores and on your particular Black Friday website that you might want to use. They're readily available for different window sizes, and they meet a standard that still allows a window to be used for egress. Excuse me, meaning they will hold back a child, but they won't hold back an adult. So some other things that you can do in existing dwellings is installing guards or limiters, restricting the opening to 4 inches or 100 millimeters, close and lock windows with low sill heights when small children are in the house. Don't put furniture up against the windows, and understand that screens are not safety devices, even if there is a screen. You can do things like removing the crank from awning windows or casement windows, and only opening the top portion of a vertical sliding or double hung window instead of the bottom portion. Simple precautions that can be taken in existing dwellings.
And so our next steps, once hopefully the National Building Code is changed here in the next few weeks, is going to use any and all publicity we might gain from the change of the National Building Code to mount a public awareness campaign, hopefully before the window fall season starts again in earnest. This is where the importance of a strong national injury prevention community is so clear. We need to use the expertise of IP experts in different locations across Canada and with different expertise, i.e. knowledge translation, media relations, marketing, etc., to get the message out. We're continuing our partnership with the City of Calgary and their communications team to garner media attention here in Alberta. And certainly we hope to work with colleagues in building safety and injury prevention across the nation to raise awareness and translate our knowledge into meaningful change in risk perception by families across the province and hopefully the entire nation, as we have with bicycle helmet safety and our Back to Sleep safety campaign. And so the next steps, there's certainly more codes that require changing. But what we've learned is that this is a marathon, certainly, and not a sprint. It's long, it's complicated, it's unwieldy, and it takes years. And it truly takes an expert with a seat at the table, like Bruce and Marco.
So the Canadian Commission on Building and Fire Codes is the central body for the development of the codes. The provinces participate by providing directional input to the Provincial and Territorial Policy Advisory Committee, which is a PIDIPAC, which is the green box on the screen. And the Canadian Commission on Building and Fire Codes, or CCBFC, is the central body. Out of the CCBFCs, there's 9 standing committees that you'll see in the white boxes there. And in the case of the code change proposal that we put through, it went through the Standing Committee on Housing and Small Buildings first. The standing committees help each other out if there's issues that are jointly, if there's a fire protection issue, for example, on housing and small buildings type of building, fire protection may share in some of the research and the consideration of the issue. CCBFC will direct those kinds of things, and the standing committees all report into CCBFC. So how can you become involved? There's a few different ways that you can participate in the process. First of all, the codes are open to the public. You can participate in public reviews. In 3 out of the 4 years of the code cycle, of the 5-year code cycle, there's public reviews generally each fall, starting in usually sometime in September, ending in late October into November. This year there's actually 2 public review processes. This first one will be ending in a couple of weeks. The second one begins in January. Meetings are posted on the NRC website, and I've provided the link there that hopefully will work when you get a copy of the presentation later. And from that link, you can also get to other parts of the NRC website dealing with the codes themselves, and you get a more detailed explanation of the codes. You can volunteer for committee membership. And you can participate in the National Codes development on a standing committee or as a member of the commission themselves. NRC is always looking for members from various walks of life. You don't have to be a code expert. Some of the best questions have come from people who are not code experts. They're just asking the simple question, why, when other people may have just made the assumption. Anyone can request a code change. All you have to do is go to the NRC website. There's a particular form you fill out, and it helps you, guides you through the form. But the main thing I wanted to point out is the meeting schedules. If you wanted to listen in on a meeting, see how things progress, most of the meetings are done by teleconference. There's the standing committees meet usually once a year in the spring, face-to-face, in various locations across the country. But all you need to do if you wanted to participate in a meeting is there's a link on that website that'll tell you how to contact the secretary of the commission to let them know you want to participate in a meeting. There is other ways you can participate in the process, getting to know your local officials, either municipal or provincial, and letting them know that you have information that may be able to help them if they want to look at proposing a change for something that's they've noticed is a concern in their jurisdiction.
And I will point out that when I was at a number of these task group and standing committee meetings, there was only one injury prevention expert, a public health nurse from Hamilton, who sat on the committee. So while there were 30 engineers and building code experts and fire experts and window manufacturers sitting around the table, there was only one injury prevention expert on this committee for something that administered chairs, stairs, handrails, windows. So there is certainly an opportunity for more members of the injury prevention community to get on board and have a seat at that table. And so lessons I learned is you need an inside expert, and many of us have expertise that we could contribute. It's a team sport. It requires high level and committed members, particularly the City of Calgary staff, Bruce and Marco in this case. You need an in with the committee that makes the changes, so the task group and the standing committee, and certainly if you have a seat at the table, you're the in. And then you need buy-in from across the country. And we had 20 different institutions or people from 20 different institutions across Canada providing letters of support for this initiative that really got the attention of the task group and standing committee when we were demonstrating this was an issue that deserved their attention. The other lesson that I learned is that healthcare voices are amplified when we take them outside of our natural domain. And I think this is something that sometimes is lost. We sit in our injury prevention groups and everybody at the table is in injury prevention, or as a physician when I sit on the trauma committee and everyone on the trauma committee is a physician. We lose sight of how important our voices are when we take them outside of our natural domain and sit around a table with architects and engineers and building codes officers and tell them the medical perspective that they don't have day-to-day knowledge and expertise in. And in conclusion, we'll talk a little bit about the 3 E's of injury prevention, which many of you, if not all of you, are very well aware of. They've taught us that we can engineer a safer environment, we can enforce policy and legislation, we can educate our citizens to prevent injury. We've talked about the importance of education in phase 2 of our project to help prevent pediatric window falls. But experts in IP would agree that the most impactful of the 3 tenets is the one in the very top. That which experts like Bruce and Marco are responsible for, the engineering of safer products and a safer environment. And I can think of no better examples of this than in the evolution in the design of the automobile. I love this picture. I look at it and I see the vestiges of an era I can imagine was as beautiful as the inside of this car. All I can see is shiny chrome and red leather. But what I can't see is a collapsible steering wheel, or the crumple zone providing a safety cell and protected life space, or a shatterproof windshield, or any form of seatbelt, let alone the 3-point restraints that we count on today, or an airbag. Moreover, I can't see the roads this vehicle used to drive on, roads without the safety engineering, speed limits, bike lanes, etc., that have done so much to keep us safe without most of us even realizing it. Things that would have seemed outrageous 50 years ago when this car were built are now very much the norm in automobile and road design. The success of these measures in saving lives and reducing injuries is indisputable. People every day walk away from collisions unscathed that used to routinely kill or severely disable people. In fact, you could morbidly consider that the shortage of organ donors over the past number of years may in many ways be attributable to the fact that people are surviving motor vehicle crashes in record numbers as a direct result of the life-saving changes in design, engineering, and legislation surrounding motor vehicle safety. The question is, can we achieve the same strides forward in designing safer homes for our children? Injuries are predictable and they are preventable. We hope that our journey to change one Canadian building code to prevent one particularly tragic and incomprehensible type of pediatric injury will serve as an inspiration to all of you to continue the invaluable work you do to advocate for the changes that will help us prevent other predictable patterns of injury. And we hope that, armed with more information on the ways we as IP professionals can become involved directly with the National Research Council to affect regulatory change, some of you might become inspired to become involved in the regulatory process as medical experts, observers, or maybe even task group members with a voice directly at that all-important table. What I've learned is that we need to get out of our lane and amplify our health expert and IP voices at the exact tables where changes are made if we want to become change makers. And by so doing, together we can continue our invaluable work to prevent needless injuries, such as pediatric window falls. I'd like to acknowledge and thank Bruce Schultz, Marco Civitarese, Mr. Stephen McFall of CHIRPP and Public Health Agency of Canada, Dr. Manu Kundra, William Craig, and Ms. Neelam Mabood at Stollery, Dr. Jonathan Gilpa and Ms. Sherry McGilvery at the ACH Trauma Committee, Ms. Trudy Sanger of CHIRPP here in Calgary, and the IP professionals across Canada who helped advocate for this change. With that, we conclude. So Shamiza, from here, we'll throw it back to you.
Thank you. Thank you so much for your that wonderful presentation and for really sharing your extensive knowledge on just pediatric falls from windows. So we have one participant so far submitted their question in the Q&A box. So I'm encouraging now for all participants who have any questions to throw them in the Q&A box. And Bruce and Michelle, did you guys want to maybe open up that box and just read those questions out live, and we'll take it from there. Oh, I see some more. So take it away, guys.
As soon as I can get to that box, I will do that.
Sure. Well, I'll read out the first question in the meantime. So we have a question that's, what advice would you have for community housing services in making it easier for low-income families to adapt existing dwellings?
I think the main thing would be to assess what the sill height of an openable window is. If it's lower than 900 millimeters, there should be some sort of prevention device on the window to keep it from opening too far or providing a guard on it. Okay. And also cautioning not to put furniture up against windows.
I think, and I would add to that would be, I think again, once people are aware of the risk, some of these solutions are very inexpensive. These aftermarket devices are not expensive to install. And so if we were to target specifically groups that had less money available to them, they're inexpensive for local health authorities to buy and perhaps distribute to people in need once they're aware that there's a risk. So I think really the first piece is information. People need to know it's a risk. Including not just people living in the homes, but perhaps the landlords or the municipal housing authority, and then getting the aftermarket devices available to them, I think would be very important.
Okay, so I've got access to the questions now, so I'm going to try one, and the second one I'll maybe get Michelle to address. The first one is a concern about window guards that I hear from parents is regarding fire safety. They worry their children will get stuck in a room without a parent during a house fire, and that the child won't be able to open a window with a guard by themselves. I recognize that this would be a rare occurrence. How would you respond to these parents? I think you're right. It would be a rare occurrence for a child to be in a room by themselves with a window that had a guard on it. The guards are easily disabled by an adult, but the intent is not to be disabled by a child. But that's not going to prevent the fire department from getting into that window, and it's not going to prevent an adult from getting out. So, there's going to be a reason for the guard to be on there in the first place, because the window is too high to begin with. There's too much of a drop on the far side of it. So I think that the trade-off in the safety there, I think, is definitely worth it.
And again, I think that points to the goal and the help in changing the National Building Code. When you change the National Building Code, you have to consider fire egress. So that was a consideration that came up at the table multiple times. So certainly for new windows, it becomes a little bit easier to just have an appropriate sill height with a window that opens fully. Nonetheless, I think Bruce spoke to that really well. And so the next question, we'll get back to the health practitioner's question, but we see when standing committees review data sets such as those provided by CHIRPP, there are always gaps. Are we able to influence future versions of reports such as the Cost of Injury 2010 report to bridge those gaps? I think that's a really great question. There is, and certainly I'm not directly involved for the Cost of Injury 2010 report, and we're certainly waiting for a more current version of said reports. I think it's tricky. I think what becomes really important is if we in the Medical and Injury Prevention Committee or our community can make our presence known and can make our expertise available to the standing committee or task groups on specific issues, then we can help bridge those gaps. Because I don't think the vast majority of the standing committees are not going to be aware of what's available in the medical literature to outline injury data, and I think that's where our role becomes really important, is helping to find the most current and the most complete set of data, and then when there are gaps, attempting to fill those gaps for the members of the task groups in the standing committee. I think that's where our responsibility is, really, is acting as the bridge between the available medical data and the members of the standing committee who are not going to be familiar with it. So I hope that answers that question. And then we have another question, perhaps the last one. What is needed to bring health practitioners to provide input or contribute to this issue? So, just to be sure I'm understanding. Really, I think what we've seen here at this table, Marco and Bruce and I are all sitting around the table, is really just bringing people who are interested in this topic and have different things to contribute to any specific issue around the table, and figuring out what information is required, who has what information, and how we can work together. So in terms of the health community, I think what's really important is just establishing the relationships between members of the IB community and members of the regulatory community like Bruce and Marco, so that if they have an issue that comes up, they'll often actually approach me on and say, listen, this is a change we see coming up. Is this something you could help us with? And if it's not for pediatrics, it's not in my domain, so I'll forward them on to other people that I know who are in the injury prevention community who could speak to adult injury patterns. Or if there's an issue that I can help on, then I can start mobilizing and getting the people that I know in the injury prevention community involved, or I can start to fill the data. So I really think the most important part is just being sure that we're not all operating in silos, that we build these relationships between regulators and health professionals and injury prevention professionals, so that when issues come up, we know who to approach and who to talk to. So if I start to see new injury prevention in the emergency department and I'm concerned about it, and it's something that Marco or Bruce could help me with, or I think one of their regulatory colleagues could help me with, then I can approach them and they can put me into contact. So I really think it's all about building these relationships, and this was an eye-opener for me. Bruce, how about you?
Yeah, for sure. It was a major piece that was missing from the code change process, was having data to be able to support it. And it was a welcome piece of information that when we found out that there was this information that was available, even though it was in its infancy of development. So we've learned an important lesson to be able to keep the channels open to the medical community as well, and in other discussions with other types of organizations as well. Keep the channels open. You never know when you may be able to use the information that's out there.
Okay, guys, we're out of time and we're 2 minutes over. So thanks everyone for sticking around, and thanks again for joining us and engaging in this really great discussion. Sorry to cut it off. So just as a few things to wrap up, for more information about the Fall Prevention Community of Practice, please visit Loop Junior at junior.fallsloop.com. And when the webinar has ended, you'll be redirected to Zoom and invited to participate in a short evaluation survey. So click on the blue continue button in your browser and you'll be redirected to that survey. And we just really appreciate if you could provide some feedback about this webinar so we can continue to offer additional webinars such as these. And I think that brings us to the end of this webinar. So thank you all again. And thanks again, Bruce and Michelle. And I hope you all have a wonderful day. Thanks.
Thank you very much.